Welcome back to Building Better Businesses in ABA with me, Jonathan Mueller. It's a weekly podcast about the forces reshaping our autism services field. Learn from successful entrepreneurs, payers, investors, and leaders in applied behavior analysis. Thank you, kind listener, for letting me into your world today. Now on to the show. James Craig is principal of Behavior Change Consulting, LLC, where he advises ABA providers and payers on service quality and strategy. James was formerly the VP for Autism Services at Beacon Health Options, the largest U.S. autism services managed care payer. Most recently, James has served as the Director of Payer Relations at the Behavioral Health Center of Excellence. James, welcome to the pod, dude.
Thank you, Jonathan. It's always great to talk with you. I've always enjoyed our conversations and these podcasts, and I listened to a number of them. It just adds so much collective knowledge to the ABA provider community, and it's very welcome.
Thank you, James. That means a ton to me, sir. Remembering when we first officially met, you may not have any memory of this, but it was at an Open Minds conference in Philadelphia. In Philadelphia, exactly. It was November of 2019, so just a little bit before COVID. Here was the funny part of that. It was about autism services and payer and provider relations. And my business partner, Will, and I were like walking around as we were just entering in the morning looking for, hey, where should we sit? And we saw a table with James Craig, the legendary James Craig at it. And I think there were a couple other payers there too. We're like, oh my gosh, we have to do anything we can to get it with James. So I hope we didn't come across as creepy, but I learned so much, and I still have the notebook from taking all of the different notes about what you were sharing. So thank you for being willing to come on and talk about everything that you've learned over your career. And let's start there. What inspired you to get involved in the autism services community?
Yeah, so I come from the behavioral health provider as well as payer worlds. I'm not a BCBA, although I was trained in behavioral therapy and also family therapy as a licensed clinical social worker. In private practice, what I found myself doing as a sideline was working with kids and families with developmental disabilities that weren't being accounted for in the classroom. And so I found myself in a lot of IEP meetings. Also worked with a lot of families of gifted kids, similar advocacy problems, believe it or not. So in addition to that, on a personal level, I became a parent of a brain-injured 3-year-old boy, as my nephew, who had failure to thrive. This was because of a sepsis infection he had when he was 6 months old. It sealed off parts of his brain and also parts of his limbs. And he had been in a neglected environment. So what it resulted in was a lot of meltdowns, as you can imagine, and behavioral difficulties. He's now an adult. He has a bipolar 1 diagnosis, and it's very difficult for him to get appropriate placement and supervision when he goes off his meds. For that reason, I have empathy for families with autistic kids and who are living with ASD. And when I was recruited by a former colleague at Beacon Health, I jumped at the chance.
I honor you on your journey with your son. And as you described, you get it. You get it what families go through. And, at Beacon, you were a vice president who managed the autism benefit. Tell me more about that role, James, including how did you and Beacon define success for the autism benefit?
Mm-hmm. Well, first, it had to do with how we interacted with providers. Then how we developed relationships with them based on experience, and much later, data. So Beacon used a consultative model using BCBAs. They had at least 5 years of experience. Our goal was to spark better care for the cases that we were managing. We then acquired a new and larger company that was treating autism as unproven, although it was a community standard. And it was using behavioral health professionals who are masters in counseling and so on, who really didn't have training in ABA. And so a lot of what I did for the first couple of years was to bring all of those national teams into some kind of compliance with evidence-based practice. And this was also at a time when the CMS was rolling out the EPSDT in July of 2014. It was like throwing all the balls up in the air at once. And so I also was able at that time, though, to help craft the Medicaid program for New York, Maryland, Florida, and California, working with state officials and also Medicaid managed care organizations. So it was a crazy and exciting time. It was a seismic shift in funding that opened up treatment availability for kids like never before. Mental health parity happened too, which was responsible for limiting day and dollar limits and all that in all but a few cases is now finally being enforced by the federal government. So initially it was to ensure that there was consistency in the way that we managed cases and the way that we worked with providers. We got some huge contracts we had to learn how to manage. So when you bring a Medicaid program on and you're getting 8,000 cases on day one, that's a little bit different than when you bring up a contract and you're scaling up or ramping up in some sort of way. So we developed a role called the Provider Quality Manager. And these were field-based staff. Some of them were BCBAs, some not, who were responsible for meeting with providers and addressing issues of mutual concern. And we also developed protocols for site visits and chart audits, along with recommendations for how they could improve their responsiveness and also their services to children and families, as well as their documentation. Early on, there wasn't really standards for documentation, and some of the providers got in trouble. They really didn't have the documentation that was going to support the billing, and there was recovery that was in thousands of dollars. But that's become increasingly rare now, and especially with the EMR platforms that the providers are using, it really helps to shape the documentation, and that's not such an issue anymore in terms of compliance.
Yeah, and just to explain, it gut check me that I get this right. So the way that payers go out and get business is they're bidding to states to manage an autism plan. So there will be any number of different insurance companies that are bidding on that. And then the state awards the plan. And in this case, in these different states you described, Beacon is managing that benefit.
Well, sometimes Medicaid side, either it's administered centrally and you get a whole contract and you have a direct contract with the state, or it's funneled through managed care organizations such as California through MCOs, and you're a behavioral health partner for them for autism, or maybe for all behavioral health services. And that's the way that you get the business.
Gotcha. And you started to speak to some of the challenges, like initially documentation, right? I know much of our field 10 years ago, as this all was coming about, was still in pen and paper. But what were some of the other biggest challenges you experienced working with providers in your role and setting up this benefit?
Yeah, so we dealt with providers of all shapes and sizes, from single providers to multi-state, multi-office, high-growth people. And size really didn't matter. There was great variability in the quality of services. Sometimes it could be between provider groups, and a lot of times it'd be within a provider group. So you might have a look at the charts, for example, within a single office, and you can see there's a lot of variability in terms of documentation and the administration of parent training or collaboration, whatever you want to refer to it, and even supervision. And then you also had with the high growth groups, at times you had variability in terms of different offices that they themselves were working on compliance and bringing things, along. And then you add into all of that the relative newness of the field. So with, BCBAs, half of them being, I guess it's within 4 years of their training. If you think about a medical system where half of your doctors had 4 years of experience or less, you would expect to have some variability, right? But you also have to have mentoring, and you have to have an infrastructure in these groups to provide onboarding, to provide develop. And so a lot of that isn't built. So the other things that in terms of parent training, one of the Medicaid programs that we were collecting data on showed that in 48% of families received 1 hour of parent training a month. Okay. Now, if I was living at home with a kid who was impacted with autism, and I didn't know how to respond to them in terms of a skill issue or a behavior issue, that would be a problem. You'll hear me say several times throughout the discussion, parent engagement is so important. And in a lot of cases, it's thought of as being kind of a secondary concern. It's not as important. The other thing is collaboration with providers. So if a doctor knows that your kid is in care and is improving or getting status updates, that's a whole lot different than mom or dad coming in every 6 months or every year and not having any information beyond what was going on yesterday with that family. All right. So all those things are really important. And finally, medication. So 50%, according to some studies, 50% of kids with ASD are on one psychotropic, 15% are on two, and 15% are on three or more. And it has a lot of implications for behavior management and also for understanding side effects. And so what are the side effects? A lot of these meds too are off label. And what we found is that kids with ASD, when they're administered medication, they really need to have lower doses, almost subclinical by anybody else. But they're very sensitive to medication. And so it's very important. So there really needs to be understanding with ABA providers around medication, its use, what to look for, and when to speak up if they see any concerns.
Wow. And that almost seems like in the Maslow's hierarchy of needs and just knowing everything that ABA providers end up doing or not yet doing, because we're not fully, at least I think a lot of our field doesn't necessarily consider ourselves in the medical model, though we clearly are. That's like getting up toward the pinnacle. I remember in our conversation, you had this beautiful framework and it's quite simple. There's elegance and simplicity, but some of the metrics that we look at might be around just time to intake, or you described just how much parent training is happening. And it feels like for a lot of insurance companies or a lot of ABA providers, even those metrics aren't necessarily getting reported back, or they're not expected to be collected. And so is that how you as an ABA provider build a strong relationship with a payer, is share information and data? Or what advice would you have for us as providers to develop those strongest relationships with payers?
Looking at the horizon, almost all payers or providers rather are considered to be pretty much at the same level. There really isn't a lot to distinguish them other than volume cases and volume of claims. That's all that payers have. So there is a lot that you can extrapolate from that. And we did. At Beacon, we put together a dashboard. It was almost totally based on claims data. It was very revealing. It measured things like dosage, access. How long does it take to have an assessment appointment after referral? How long does it take after that to have your first treatment appointment? And then what is the dosage that the provider recommends or is the average across the board? How do you risk adjust for that in an organization? This is part of, I think, profiling. Some providers have a very narrow band of kids that they admit to their programs. So one provider, for example, will tout the fact that they have a high percentage of kids that after 14 months are mainstreamed into schools, but they highly curate the kids that are coming in. So when you think about things like length of stay, when you think about number of hours a week, all of that, you have to take into account what's the range of the level of impairment that a provider is willing to work with. What are the ages that they're willing to work with? Is it mostly preschool kids? Or are you also working with school age? Are you working with adolescents, which, by the way, is a very underserved population? If you think about young adults and people moving into adulthood, that's like a whole nother universe practically. Okay. And that's a problem of funding as well as of provider inclination or provider training or anything like that. So what you want to develop is a relationship with a payer. The way to do that is to provide them with data. Now, right now, the only data that they have is case specific data. Okay. That's pretty easy to get because that's what your EMRs are set up to do. Right. And so you can get a return on here's the number of goals that were accomplished. Here's the parent goals and here's what's going on with that. But really for a provider to understand or a payer to understand you as a provider, the more information that you're passing on, the better. And so really we're talking about transparency. Okay. And for some providers, in some cases that feels risky. You're talking about responsiveness. So if I have a question, a case, Does the provider talk to me? Do they answer my calls? And is there a need on my part to reach out to this provider frequently? So what's going on now, for the most part, is case-specific types of interaction. And what I think we want to move to is, when you're talking about things like value-based care, is really understanding your population as that, a population. So what does that look like? Who do you work with? How engaged are parents? What is their role in treatment? And, what are your outcomes? We're starting to really kind of get a feel for this, and it comes down to measurements. I've sat in conferences, and you have too, where for the last 5 years, people have been talking about measuring ABA, right? Part of it is that when you think about measurements such as HEDIS measures or other measures that would lead you into a value-based care relationship, part of that is that autism kind of lacks a lot of those things. So you're not measuring responses to medications such as ADHD meds, or you're not measuring antidepressant. You're not measuring the percentage of admissions into inpatient or readmissions to inpatient, because they're pretty rare. They do happen, but they don't happen all that much. And so usually when you have a value-based type of relationship, what you're trying to do is you're trying to have cost avoidance for high impact and high cost events. Potentially, any case in ABA can be a high cost event. When that's all started, payers were scared to death because they thought that every autism case was going to be $1 million case. That didn't happen for a couple of reasons. One is that the supply of providers was so low and was such a poor match to the demand that was going to happen. And so that didn't happen. There was no curse splash to invoke Peter Pan here. Okay. And so what we saw was underutilization, I think, in many, if not most cases. Well, then what's happened is the supply has greatly increased over the years. In some cases, it's doubled. I think over the last 5 or 6 years, it's doubled in the number of BCBAs. And so what's happened is we've seen increase in enrollments, we've seen an increase in utilization, and it doesn't really show signs of plateauing. Okay. So payers are worried. Providers at the same time are worried, because the worst outcome, and this is the thing I'm most afraid of for the field, is that payers will say, we're just going to drop the rates. And it's happened in a couple of cases where the rates have been slashed by maybe 20%. Problem with that is a lot of the services that ABA providers do are not billable. The enrichment, the onboarding, the development, the CEUs, that's all those things that are part of a quality organization, whether it's an ABA organization or any other. And that's one of the reasons I really like your podcasts, Jonathan, because it really brings into relief. It's the same problem. If you have an ABA organization, you have the same issues as any other organization that's providing services. You have to figure out a way to bring people. You have to figure out a way to engage them. You have to figure out a way to keep them. You have to build a culture. You have to build an infrastructure of learning, all of those things. Well, those aren't paid for in a lot of cases because you can't bill for those. An alternative to slashing rates, which is going to disadvantage everyone except for maybe the leanest and maybe poorest providers, is to begin to have a data-based relationship.
There's so much to double click on in what you just described, but let's look at what would prompt a payer to just unilaterally slash rates. I mean, is it entirely a budget thing? Is it a quality of the network thing? Is it other reasons? Help me understand what's going on as that happens.
Well, first of all, there aren't a lot of levers to manage ABA benefits, really. So at the outset, there were dollar limits, there were day limits, there were benefit limits that payers could apply to kind of keep things within a certain way. That went away with mental health parity. Secondly, you could have two similar cases and wildly different recommendations for dosage. Where does that come from? And how do you make a determination between a kid needing 17 versus 20 versus 25 versus 30 hours a week? Okay. There are criteria that have been developed for that. Interqual, for example, I think is one that some of the managed care companies use. Some of them use their own criteria, but it's subjective. And so really what you want to understand is any particular case, this is time consuming. I mean, again, you think about a case by case model and understanding a provider from an individual case perspective. It can take 45 minutes to go through a case. You've got a lot of information there. You have goals, you have charts and graphs and all kinds of detail about how a child is progressing. And I would say there's white noise. So there's a lot of information in there. Where is the signal? Where is the signal that shows you what is actually happening? One of the ways to get to that in a more concise way is to utilize assessment tools. And so some of the newer things that have happened, the ICHOM has developed a program where they're looking at core symptoms, and they've settled on the Vineland and the Child and Family Quality of Life Questionnaire. The Lancet published an article last year where it talked about addressing autism in rich countries and addressing it in poor countries. And a lot of the ICOM is along those lines too, because it looks at countries that can spend a lot of money on assessments and countries that can't. And so there's two sets of recommendations. If you look at some of the managed care companies are utilizing assessment-based tools. And so one of them utilizes any norm-based tool. Another one utilizes a Vineland in every single case. TRICARE has their own record of tools that need to be used. Well, from a simplistic point of view, you can look at a profile. It's color-coded. You can see where some of the changes are happening. You can look at that profile. And if you have a question about one of them, you can refer back to the notes or refer back to the report. That's a quick and easy way to say, okay, I actually can see the progress that this child is making.
Something really powerful that you mentioned earlier. Actually, you subtly sneaked it in, but it's really true. As a payer, most ABA providers look the same. There is no way to differentiate who the good and who the bad ones are, but there's a bell curve, right? And there's a probability of distributions of quality of providers. And I think it's easy as an ABA provider to forget this, right? To know, hey, I'm special, and here's why I think I'm special and why we're great for family. And yet, if as an ABA provider, we're not helping our payer partners understand why we're special, then the fight is lost. Right? Then you can't even start a relationship. And so I think this is a really powerful reminder to make sure data, outcomes, um, satisfaction scores, whatever it is, be communicating these back to your payer. That's part of what underpins a strong relationship. And I want to start talking about value-based care. Before we do, though, you used the term risk adjusted. Can you just talk a little bit more about what that means in the context of a payer and how you think about population and individual sort of member management?
So if a provider is talking to me about their average dosage, their average length of stay, how can I be sure that I'm dealing with apples to apples versus apples to something else? And so risk adjustment means, to be simplistic, is looking at initially some sort of measure of severity. Okay. And you can get that. You can get that from the ADOS. You can get that from the SRS2. You can get that from the CARS2. And sure, it's not perfect. It might be somewhat rough, but it's a start. So a way to think about this is, okay, if I'm thinking about like a range, okay, so on the low end, what would the low end scores that I would obtain from people that I'm working with? And what would that look like? And where is the median or the mean? Okay. That gives a lot of information about the kind of practice I have. For some, it's going to be very, very narrow. And then if they come to me and they say, well, I have this results and we have a graduation rate of this. I can adjust based on the fact maybe they're on the lower end of impairment and maybe they have a smaller corridor, if you will, okay,
Mm-hmm.
a smaller range. That means a lot more to me than someone saying to me, touting this great response that they have to treatment against a provider who maybe takes all comers, who works with people who are very impacted and people who are less impacted. And then that helps me understand why those length of stays or graduation rates or dosages might be different. So if you can break out age groups and stuff like that, you can even get to it, I think, further. But the idea is to adjust it based on the population that you're serving, and not every provider serves the same population.
I got you. And that adjustment that you referenced based on the risk adjustment, that's ultimately important so you could compare providers' clinical outcomes, or so you can predict and budget what you might have to pay for services for certain providers versus others, or how does an insurance company use that?
Oh, well, they're not using it now because they're not getting it.
Fair enough.
I think, again, with transparency, the risk is that, you're going to be opening up all this information. Payer is really going to be able to see what goes on. That does feel risky, I think, in some instances. So it's about the relationship, though. If you have that and you're furnishing this data, that will evolve. Here's what I've learned. When you provide data to someone, it always provokes questions about what about this and what about that, and more questions and more data. But that's in the context of a relationship. I'll give you an example of maybe how this worked. When I was at Aetna, we worked with inpatient facilities for behavioral health. My group was responsible for the Eastern United States. Most of our concern actually was in the Northeast. Okay. So what we decided to do was, instead of reviewing every single case, patient basis, what we would do is we would generate data based on the care managers who are reviewing it and based on data that we collected, that they collected. Okay. I think with autism, it's going to be hard for payers to actually take up. Anyway, so what we did was we developed a dashboard. Every quarter, we shared the dashboard. So we had their performance in that time period, and we had their peers' performance in that time period, which was very effective. One thing we noticed, like within a very short period of time, was the utilization went down more than what we had been able to do when we were managing these cases, every 3 days or so. And it's not a satisfying relationship. Autism is not all that different from the rest of behavioral health. Behavioral health, you're dealing with a nurse who's reading a chart. And so if you have a question, that nurse says, okay, well, I'll go back and I'll ask the doctor that. Is that a satisfying relationship? Oh, so what we did was we had quarterly meetings with the facility, and that included the CEO, the CMO, the director of nursing, the director of social work, all these people poring over these documents, whether it was in person or whether it was over a conference. And so we didn't touch a case for the first 15 days. And that's going to be 90% or more of cases, patient behavioral health. My hope was that we could bring that same thing to life with autism, okay, where we would develop a dashboard that we'd roll out. We'd have discussions. We'd notice trends. Oh, look, we noticed your enrollment went this much. What's going on? We noticed that you had more discharges. What's going on? And we did, for a part of Beacon's business, we did develop a dashboard. It was largely based on claims, but included other things too. And we brought them out to the providers, and contractually, I think we had to meet with providers once a year, but I think in reality, we met with many of them every quarter, and we shared this information. But that means that the payer has to develop analytics. A lot of them are not going to do that. So what it means then is that the providers have to do that. Whether it's fair or not, I don't know. But you have to represent the work that you do somehow. Whatever it is that you can provide in terms of, first of all, engaging in a relationship. Nobody's going to do value-based care off the bat. Okay. You're going to have some period of experience together where you're sharing information. There are some rare instances now where there's some bonusing that's happening. Okay. So, hey, based on parental satisfaction, for example, one of the measures is the number of hours that were authorized versus the number of hours that were actually used. And those are rated. And depending on how providers do, they get bonused on that. So that's the first step, I think, in value-based care is that you set up a goal, and if it's exceeded, or if it's met or it's exceeded, it's rewarded. And then the next is taking on more risk. All right. So if I say I can do cases for a certain amount of money per month that we can settle on, that's predictable for the payer and it's predictable for the provider and it works for them, that would be the next, and all the way into subcapitation. But I don't see that happening because that means you're totally responsible for somebody's health care. And that's not going to happen, I think, in ABA. So I think the more information, outcomes data, parental satisfaction is a big marker there. I think if you're talking about assessment results, using some of the tools that were already mentioned, graduation rates, discharges, and so on, those are outcomes.
So is it a fair characterization? You use the word predictability, that one thing payers crave is a predictability of knowing, hey, this kiddo is going to be with this provider for a certain amount of time. It's not just sort of an endless thing, but there's a predictability, which then leads to a payer being able to accurately predict what they're going to have to spend on that case. But is that a fair characterization?
Well, usually the way it would work, and again, this has to do with using tables to figure out what happens. So year one might be a certain amount. Year two might be a lesser amount. Year three, and so on. It really comes down to having a sense of your own practice about that way that works with your cases. That's going to equip you to be able to have discussions with payers that are informed, that are going to serve you well. And if you don't have that information, then it's going to be very difficult to go into that with eyes wide open.
And that's part of the challenge of our field not having moved yet toward a value-based relationship. So what are a couple of the other things in addition to outcomes that need to be true in order for ABA to move toward more value-based care models?
Well, so we talked about access already. You can talk about the tenure and years of experience of your staff. You can talk about service locations. You can talk about place of service. Do you do home center, hybrid, telehealth, language and cultural competencies, turnover rates of staff? We have benchmarks for that stuff, and it's a proxy for continuity of care, right? In terms of performance, you can talk about length of stay, dosage, weekly ABA hours by age group, and caregiver engagement, evidence of collaboration with other professionals. One managed care company that I know of insists that you do screenings for depression at age 12. Every age 12 has to get a screening. So I've suggested this to ABA providers. What they come back with is we're not able to do that because we're BCBAs. Nonsense. Office staff, pediatric practices do this all the time, and they're not trained master's level people. What we know is that children with ASD have a higher incidence of anxiety disorder. They have a higher incidence of depression, especially when they get into the teen years. They have a higher incidence of substance use as well. They also have a higher risk of suicide. And so if you're doing these screenings and you have a way to refer them out, some practices are even hiring behavioral health people, mental health counselors or social workers. So those are addressed, those points are addressed at intake. Not to mention, there's also the family. All right. Again, this is partly out of my lived experience, but partly because I was a family therapist. Having a child with autism within your family is a major, major stressor. And it produces all kinds of role changes for everybody in the family. For the parents, there's an impact on jobs. I think 14% of the time, one of the parents has to stop working. Okay, that's terrible. There is a higher divorce rate among parents. Siblings, very underutilized. I mean, there are some groups that do sib groups. Those are kids that either are invisible in a family or they become part of the parent group, kind of. And so all of those people need help. They all need support. They all need possibly treatment. So if you can assess for those things, even if you're not yourself as a BCBA, someone who can make a diagnosis, still screening for people and have a sensitivity to it, to what you may be seeing or what people may be undergoing. I'll just give you an example. I'm reading a chart and mom and dad are divorced. It was a case where a child, a behavior had spiked considerably. And what had happened over the weekend is that dad and mom had separated. That wasn't anywhere in the notes. It was like, well, the behavior increased dramatically. Again, you have to be thinking about this in the context of what's going on with the family as well.
So well said, because no child exists independent of that family context, that environment. James, what's one thing ABA practice owners should start doing and one thing they should stop doing?
To repeat myself here, and is increasing meaningful family engagement. This was a real hot topic when we were doing training with providers in Massachusetts. This is a real hot topic because it's not part of the standard ABA curriculum. So you have parents that are sometimes intrusive, of parents that are sometimes, one example that comes to mind is the parents have to be home when there's an in-home session. What happens? Mom goes to the grocery store, dad goes out and mows the lawn, right? Are they getting anything? Are they observing what's going on? Are they getting anything out of it? And when that happens, what is the BCBA? What is their reaction? And how do they address that or manage that with a particular family? And it's understandable. It really is. Families need respite and they need time to do other things. And then in center-based cases, a lot of times it's difficult for families to make it in. If you can get in between 8 o'clock in the morning and 6 o'clock in the afternoon, if you can't, you're out of luck. Or maybe all that you get is every 6 weeks, you get an update on how they're doing. It's not the same thing as equipping parents to be able to be a part of the treatment process. So I would say meaningful family engagement.
And how about for stopping?
I would say believing that providing individual case data is going to be sufficient. And we've already mentioned that. Part of the problem there, Jonathan, is that that's the way that data is collected with the existing EMRs. Okay. They really weren't designed to aggregate data. And so what we find is that providers have to do that kind of on the side. And they have to have staff that sets up databases, that tracks this stuff, that when an assessment tool comes across their desk, they log that score on and so on. There has to be a conscious effort to set up these measures and then populate them. And at least the way that it currently happens, it has to be done on a manual basis. So what is that?
Would it be fair to say that a provider who's able to share that kind of data and start to invest in that infrastructure and then leading to a meaningful dialogue with a payer, that's when a payer might consider differential reimbursement rates or other payment arrangements because providers are investing in that. Is that right?
Or even as a start developing a stronger relationship. This provider really stands out because they have this information about them. Otherwise, it's anecdotes that you get from the care managers and it's claims data. And it's really not representative of what's actually happening.
Well, James, where can people find you online?
You could reach me at info@behaviorchangeconsulting.com.
I will drop a link to that in the show notes. James, are you ready for the hot take questions?
Sure. Yeah. Let me have it.
You're on your deathbed. What's the one thing you want to be remembered for?
I want to be remembered for my curiosity and that I never stopped learning.
That is so important. Never stop learning. What is your most important self-care practice?
Running. I started running in my late 30s, and I've run in 3 Boston marathons, and it just keeps me sane. It allows me to clear my head and really come up with a lot of ideas.
What is your favorite song?
Okay, well, it's Cracker Box Palace. It's a George Harrison song, and it's a very sweet song. It's about the universality of growing up and growing on. I just love it. And it's got all his musical touches that he does as well, but it's just such a sweet way of talking about what it's like to grow up, and everybody goes through that same process.
If you could give your 18-year-old self one piece of advice, what would it be?
No matter what happens, you're going to be okay. I mean, you go through so many things in life that are first experiences, and they all feel like, it's the end of the world. But when you work through them, you understand that's not the case. You're going to be okay.
You can only wear one style of footwear. Which would it be?
Sneakers, obviously.
Sneakers, so versatile. Anything else to share?
Yeah, I'd also like to make a plug here for just a couple of programs that I've seen recently that I think are wonderful, and maybe your audience knows about them, but one of them is Extraordinary Attorney Woo. It's a Korean TV series, and it's about a 27-year-old Asperger's attorney with an eidetic memory who has all kinds of really severe problems. She has a fixation on whales as well, which comes through. And it's just such a wonderful representation of kind of being in that world, living in that world. And it's all of its distractibility and all of the difficulties with being involved in a legal system of all things, but also interpersonally. And the other is Temple Grandin. I saw this film just recently. It's from 2010. It starred Claire Danes. It's on HBO Max now. What a wonderful representation of Temple Grandin and the gifts that she had, and despite all of the limitations that she has as well. Both of those things were just dramatized to me so beautifully that with the proper support and with the opportunity, that people really can maximize what they can do and their contributions to themselves and to other people and society at large. And we have a ways to go to make that happen.
Thank you for those recommendations. I will put them in the show notes. Thank you for sharing your wisdom with us today, James.
Thank you, Jonathan.
Hey, kind listener. Thanks for tuning in. If you like this episode, can you do me a favor? Give me a rating on your favorite podcast channel. It helps more values-aligned people like you find the pod. Till next time, peace.